Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday edition. Tonight we have a very in-depth and educational topic, OCT and neuro-ophthalmic disorders, papilledema, pseudopapilledema, MS, and other neurodegenerative diseases. And with it, we have our esteemed presenter, Dr. Leonard Messner, who's a Vice President for Strategy and Institutional Advancement at the Illinois College of Optometry. He holds a rank of Professor of Optometry at ICO. He is the immediate past chair of the Neuro-Ophthalmic Disorders Special Interest Group with the American Academy of Optometry, and is currently a member of the steering committee of the Academy's Fellows Doing Research SIG. His predominant area of clinical practice and scholarly activities is the evaluation and management of individuals with neuro-ophthalmic disorders. In addition to his many other accolades, he is a 24-time recipient of Teacher of the Year Award at the Illinois College of Optometry. I've worked with Len for many years. We have worked together at the Academy, creating the Neuro-Ophthalmic Disorders Special Interest Group. It's been really my honor to have been in association with Len for so long, and it really is my privilege to introduce my friend and colleague, Dr. Len Messner. Please take it away.
Well, thanks so much, Joe. It's a pleasure to be with all of you this evening, and thanks again for that introduction. Let's see if I can move forward on this. Okay, these are my disclosures. And the key points of this evening's discussion are as follows. I'm going to begin with a discussion of papilledema and specifically the OCT findings associated with both papilledema as well as pseudopapilledema. From there, I'm going to talk a little bit about the OCT findings in the setting of chiasmal disease, or specifically chiasmal compression or insult. And from there, we're going to finish with a discussion of OCT and its relevance in a variety of neurodegenerative disorders, including multiple sclerosis, Parkinson's disease, Alzheimer's disease, and then finally work that we've been doing in the area of traumatic brain injury and chronic traumatic encephalopathy. So let's begin with a definition, and specifically a definition of papilledema. And we can consider a diagnosis of papilledema as being swelling and elevation of the optic nerves, both due to elevated intracranial pressure. So that's pretty standard stuff. If we think about pseudopapilledema, by definition, this is a congenitally anomalous optic nerve. So there's an anomalous elevation of one or both optic nerves without optic disc swelling, and typically with a morphology that shows a small or absent optic cup. And this may or may not be associated with optic disc drusen. More on optic disc drusen in a couple of minutes. So when we think about papilledema, there are a number of grading scales. The one that is most common in neuro-ophthalmology is the Friesen grading scale, and many of you are familiar with this. Grade 1 papilledema is characterized by the C-shaped halo of edema with sparing of the papillomacular bundle fibers. Grade 2 is where there is more of a circumferential corona of optic disc edema with minimal obscuration of the major retinal blood vessels as they leave the optic nerve. Grade 3 is all of the findings of grade 2, but now there is more significant obscuration of the major retinal blood vessels as they're leaving the optic nerve. Grade 4 is all of the previous findings plus significant obscuration of the major vessel findings and architecture on the surface of the optic nerve. And then finally, stage 5 is where the optic nerve takes on something of a champagne cork-like appearance, and there's obliteration pretty much of the total surface structure of the optic nerve head, as well as filling in of the optic cup. So with that, I'd like to talk a little bit about the OCT findings that we associate with papilledema. And I'd like to preface this by saying that OCT is an aid. It is not the definitive diagnostic tool, but it is very, very helpful, as we'll see is going through a number of cases in conjunction with the clinical examination of the patient, as well as other features that may be consistent with elevated intracranial pressure. So thinking about OCT analysis of papilledema, first and foremost, typically these individuals have significant thickening of both the retinal nerve fiber layer as well as the rim thickness, or the minimum rim width thickness. Typically, the optic nerve is significantly elevated above the surface of the retina, but with preservation of the central cup until very late in the disease. Now, that's important because when we think about papilledema versus pseudopapilledema, many individuals with anomalous nerves have very, very tiny cups or absence of the cup. With papilledema, it's going to be there. It'll be elevated, but it's going to be there until very late in the disease. There is a relatively new finding that is termed the recumbent or the lazy V sign, which is a V-shaped notch that is thought to be the accumulation of fluid within the subretinal space adjacent to the optic nerve. Another more recent finding is the presence of peripapillary inner retinal folds. They're present more on the temporal versus the nasal side of the optic nerve. And I'll show you some examples of this in just a couple of moments. And then finally, what I think is a very helpful differentiating tool as it relates to the OCT findings of papilledema, and that is the inward deflection of the RPE Brooks membrane complex. And this really goes hand in hand with the typical flattening of the posterior globe, of the flattening posterior eye wall that we see on MRI, and particularly T2-weighted imaging, go through the orbits among individuals with papilledema. So about 2/3 of patients that we see with papilledema are going to have some evidence of this inward deflection of the RPE Brooks membrane complex, typically more prevalent on the nasal versus the temporal side of the optic disc. So let's begin with this case of a 32-year-old woman with progressive headaches that may be a bit worse when she wakes up in the morning and then dissipates somewhat as the day goes on. Along with this, she has this periodic symptom of synchronous pulsatile tinnitus, or a swooshing sound in her ears that is rhythmic, and the rhythm goes in tandem with the beat of her heart. Her BMI is significantly elevated at 41. Remember, over 30 is considered to be obese, over 40 is morbidly obese, and her visual acuities are normal, 20/20 in the right eye, 20/20 in the left. And if we look at the optic nerves, here in the right eye, we see this circumferential corona of optic disc swelling, obscuring the juxtapapillary major blood vessels as they're emerging from the optic nerve. In the fellow eye, we see rather similar clinical findings, here with a little bit of blood involving the suprarenasal quadrant of the optic nerve. Looking at her brain, what you can see on the sagittal view going straight down the midline is this flattening of the pituitary gland against the floor of the cella. This is the classic empty cella sign that we see, or partially empty cella sign that we see in the setting of elevated intracranial pressure. We can see that the cerebellar tonsils are slightly ectopic and going down through foramen magnum. And for all practical purposes, the rest of the brain is fairly normal. So these are all findings that we associate with the pseudotumor cerebri syndrome, also known as idiopathic intracranial hypertension. Now, getting back to the OCT findings, if we look at the nerve fiber layer thickness, we can see that there is significant and almost uniform thickening of the retinal nerve fiber layer, average of 228 microns in the right eye, 161 microns in the left. And now looking at the morphology of the optic nerve in the right eye, well, first of all, you can see that there is this generalized elevation of the optic nerve from the floor of the eye wall. And along with that, there is this preservation of the central cup. Now, in addition to that, I want you to pay attention to a couple of other things. One is this inward deflection of the RPE Brooks complex. Under normal circumstances, we would expect to see the RPE Brooks complex going somewhat down, or in a curvilinear fashion, following the normal contour of the globe. But in this case, as I've drawn in with this dotted line, it's actually curling up or deviating somewhat inward toward the vitreous. And we can also see that in this case, it may be a bit more prominent on the nasal versus the temporal side of the optic nerve. Now, going along with that, we can see both temporal as well as nasally, this V-shaped hyporeflective notch. And this is the lazy or the recumbent V sign that I was referring to earlier. And it's thought that this may represent fluid accumulating within the subretinal space. Let's take a look at another case. This is a 28-year-old woman, again, coming in to see you complaining of chronic daily headaches, along with synchronous pulsatile tinnitus. Her BMI is significantly elevated at 39, and her visual acuities are normal, 20/20 in the right eye, 20/20 in the left. And if we look at her optic nerves, we can see similar clinical findings as in the previous case. Pretty much a circumferential corona of edema with some obscuration of the major blood vessels away from the optic nerve. So at least a stage 2, maybe stage 3 papilledema in the right eye, and in the left eye, rather similar clinical findings. If we look at the OCTs, and specifically we look at the raster scans taken through the optic nerves, right on the left, left on the right, here again, we see this gross elevation of the optic nerves inward toward the vitreous. There is still relative preservation of the central cup here on the right side, same on the left. The other noteworthy feature is that there is this very pronounced, particularly on the left side, inward deflection of the RPE Brooks complex. And what you can also see, particularly on the left side, is this ovoid hyperreflective structure, notably on the nasal side of the optic disc. Similar findings here in the right eye. This is something called a peripapillary hyperreflective ovoid mass-like structure, or a FONS. More on that a little bit later. But the other thing that I want to call your attention to is this folded or pleated appearance here on the temporal side of the optic nerve. And these interretinal folds are somewhat pathognomonic of papilledema, and a feature that can be fairly easily evaluated through the OCT. Now, these are variable in their appearance, meaning that depending upon where the patient looks, these folds may be more apparent, or in some fields of gaze, they may go away entirely. This gets back to the old 30-degree test that some of us used to do many years ago. It's an ultrasound test in order to look for fluid within the optic nerve. But basically, if the patient is looking straight ahead or they're looking inward somewhat, the optic nerve is somewhat kinked within the orbit so that there is this damming or buildup of fluid. And that's what leads to these interretinal folds. If you ask the individual to abduct the eye, where there's more of a straightening of the optic nerve, and there's more of there's more of an even distribution of the fluid, these folds will typically dissipate or go away entirely. But again, this is a fairly reliable finding among many individuals with papilledema. Here's another case of a 40-year-old woman, chronic daily headaches, chronic synchronous pulsatile tinnitus, BMI of 44. And what you can see here is that the visual acuity is affected, 20/40 in the right eye, 20/40 in the left eye. Now, we know as a general concept that visual acuity is preserved until the later stages of papilledema. And indeed, if we look at the optic nerves, you can see pretty much this complete obscuration of surface detail of the optic nerve here on the right side. Same thing on the left side. The cup is somewhat filled in. And one of the real concerning features of the appearance of these optic nerves is that we see the optic nerves taking on something of a pale appearance. So that's significant. With all the diagnostic tools that we have, it's still very, very important to look at the optic nerves. And we know that a pink optic nerve is generally a healthy optic nerve, and that's good. But that when the nerve begins to pale, this is indicative of more chronic disease, more permanent disruption of the optic nerve and the corresponding axons. And this is where we really begin to worry. Now, looking at the OCT findings specifically, you can see that there's considerable thickening of the retinal nerve fiber layer. 384 microns on the right side, 285 microns on the left. But looking at the raster scans, here you can see the significant elevation of the optic nerves here in the right eye, here in the left, as well as the inward deflection of the RPE Brooks complex, both in the right eye as well as in the left. And the other thing that you can see is that when we take a cut through the area of the optic cups, we can see that it is obliterated. This is material, this is axoplasmic material that is simply left behind, and it's accumulating within the optic nerve. I want to show you a case now of progression, but progression in a good direction, or I should say remission of this patient's papilledema and the OCT findings. This is a 32-year-old Hispanic woman, chronic, progressive, debilitating headaches, several months duration. She's a normal neurologic examination. She also complains of synchronous pulsatile tinnitus. We see that her visual acuities are quite good, 20/20 in the right eye, 20/20 in the left. And here we see that the BMI is 38. Looking at the optic nerves, we see the circumferential corona of optic disc swelling in the right eye with some obscuration of the major vessels just away from the nerve. And here on the temporal side, you can see this folded appearance to the retina. More on that when we look at the OCTs. In the left eye, a bit more in the way of an edematous appearance to the optic nerve. This is certainly at least a grade 3, maybe a grade 4 papilledema. I would say the good thing in looking at these optic nerves is the color. They're still pink. They're still well perfused. And of course, that's always heartening in the evaluation of a patient with any optic neuropathy. So looking at the visual fields, we see that there is an enlargement of the blind spot in the right eye. Same thing in the left eye, and quite significant thickening of the retinal nerve fiber layer. Average thickness of 386 microns in the right eye, 442 microns in the left. Looking at the MRI findings, this is a T2 weighted image with fat suppression taken through the orbits. And what you can see, first of all, to orient everyone as it relates to the anatomy, here we can see the globe on the right side. Here we can see the globe on the left side. In addition to that, you see this flattening of the posterior sclera here on the right, here on the left. Now that's literally the eye wall being pushed forward due to fluid and pressure building up within the subarachnoid space of the optic nerve. We see that there is something of a distended, tortuous appearance to the optic nerve here in the right eye, here in the left eye. And then looking at the rest of the brain, here on the left, this is a coronal cut taken through the chiasm. Here you can see the chiasmal bar. Here you can see the normal brain parenchyma. But this very thin structure, this thin line that I'm pointing to you right here, that is the pituitary gland that's flattened against the floor of the cella. So that's the partially empty cella sign that we see in the setting of elevated intracranial pressure. Same findings here, only on a T2 weighted image. So getting to the OCT, here we see a raster scan taken pretty much dead through the center of the optic nerve, elevated appearance to the optic nerve, preservation of the central cup. Here you can see this recumbent or inverted V pattern, which probably represents some fluid accumulating in the subretinal space. We have this inward deflection or inward turn to the RPE Brooks complex. And then here on the temporal side, corresponding to our clinical photographs, we see this pleated or irregular appearance to the inner retinal layers. And in the left eye, very, very similar findings: elevated optic disc, preservation of the central cup, inward deflection of the RPE Brooks complex, a bit more so on the nasal side than on the temporal side, this recumbent or inverted V pattern or lazy V pattern, and then also this folding to the retina that is evident, the inner layers of the retina on the temporal side of the optic nerve. So this is an individual that certainly fulfills the criteria for idiopathic intracranial hypertension. Her lumbar puncture was significantly elevated with normal cytology. So she was treated with 500 milligrams of acetazolamide twice a day. In addition to that, she was also very good with losing weight. She lost about 25 pounds in 6 months. Combined effect, significant improvement of her headaches. And what you can see is that 6 months later, her optic nerves, her nerve fiber layer thickness is coming down pretty well. 129 microns on average on the right side, 135 on the left. But I want to call your attention to this. You need to be careful. If the nerve fiber layer is thinning in the setting of papilledema, it can mean one of two things. They're either getting better or they're getting worse. Remember, as the nerve becomes atrophic, axons lose their ability to swell, and the nerve will thin itself down. So it's not good enough simply to look at nerve fiber layer thickness. But here you can see, looking at the ganglion cell complex, that really there is this very symmetric and robust appearance of macular thickness, and specifically the retinal ganglion cell complex in the right eye as well as in the left eye. And this, of course, is a good prognostic finding. Looking at the morphology of the optic nerves, we see that they're beginning to return to earth, this flattening of the papilla on the right side, similar flattening on the left side, pretty good resolution of these temporal retinal folds that I showed you earlier. And 14 months from the original presentation, this patient's been off her Diamox for 3 months. She's maintained her weight loss. Her BMI is now down to 30. She's headache-free. And we see what appears to be pretty much a normal appearance to the optic nerve with good color on the right side, normal appearing optic nerve with good color on the left side, essentially normal retinal nerve fiber layers on right and left sides, preservation of the normal ganglion cell complex, and restoration of normal morphology and normalization of the visual fields. So ideally, this is what we like to see among individuals with idiopathic intracranial hypertension. But I think that this case clearly shows the value of OCT, both looking at retinal nerve fiber layer as well as the vital structures of the retina, notably the ganglion cell complex, as a tool of progression, or looking for improvement of the disease process over time. So I think we're ready for our first polling question. And the question is, which of the following is not an OCT characteristic of papilledema? 1, retinal nerve fiber layer thickening. 2, elevation of the optic disc. 3, or C, a subretinal hyporeflective space between the photoreceptor layer and the RPE, aka the lazy V. Or D, an outward deflection of the RPE Brooks complex. And I see that there's another choice that's been thrown in there as well. So why don't we answer the polling question? I guess we'll give you a couple of seconds to register your responses.
Len, just so you know, that was me from our surveys. You know, we watch our surveys, and people put in these complicated cases like this at times, subjects not sure, and that's why I'm here. So I was the one that added that. You'll see that. Also, I just want to announce to everyone that I did put the handout in. You'll see one for clinical decisions of the retina. Oops, wrong one. It's the OCT Neuro. That's to be downloaded. And to remind everyone, it's in the links also, 645 link and the post-event email. So no questions have rolled in, Dr. Messner. So let me see where we are here. We're almost right. And it's kind of neat. I'm not sure if a lot of people know, but Len grew up probably about 20 miles from where I live. So that's right. Every so often I see him in town. So
and my aunt grew up in Dr. Caldwell's hometown. So,
yeah.
So
there we go.
Small world.
Yep, it is a small world. All right, so I'm going to end, Len. What will happen now is I'll share the results, and you'll be able to see now where everyone is with 17, 5, 11, 60, and 8%.
Great. Well, we jumped all over the correct answer. We're off to a good start.
Okay, so I stopped the sharing.
Okay, great. So that's OCT in the setting of papilledema. I want to shift gears now and talk a little bit about the OCT analysis of pseudopapilledema. And getting back to my earlier comments, pseudopapilledema is just another way of describing an anomalous optic nerve, in that this is the normal morphology of the optic nerve for a particular individual. But these are the clinical findings that we typically see with pseudopapilledema. And that is, oftentimes there can be an increase in the retinal nerve fiber layer thickness. There is significant elevation of the optic nerve. Typically with pseudopapilledema, there's something of an irregular contour to the optic disc. And this, in certain instances, may be due to the presence of buried drusen. But as we become more familiar with the OCT findings, this irregular appearance may be due to bulging axons. And I'll show you an example of that in just a couple of moments. But unlike with true papilledema, where you get that lazy V or recumbent hyporeflective pattern on the edges of the optic nerve, you do not see that in the setting of pseudopapilledema. Typically, these individuals have a very narrow posterior scleral foramen, which leads to an absence or a tiny central cup. And then finally is the absence of this inward deflection of the RPE Brooks membrane complex. So the RPE Brooks membrane complex tends to be neutral or negative among individuals with pseudopapilledema. With that, I want to talk a little bit about optic disc drusen, because this is a finding that may or may not be associated with an anomalous optic nerve. I think the best way of thinking about optic disc drusen is that disc drusen is a byproduct of degenerating axons within the optic nerve. Now, the most common cause of degenerating axons within an optic nerve leading to the formation of drusen is an anatomically crowded canal. So that on an individual basis, we have roughly about 1 million axons per optic nerve. If you create a narrow opening for those axons to leave the globe and travel back to the visual centers within the brain, they pile up on top of one another, and ultimately some of them may just give up and die. And as that material, that axoplasmic material, is left behind, forms aggregates that are commonly referred to as optic disc drusen, or these colloid bodies of leftover junk simply forming within the optic nerve. Now, I will tell you that you can get optic disc drusen among individuals with chronic atrophic papilledema. But one of the major differentiating features is that disc drusen with chronic atrophic papilledema, you're typically going to see that obscuration of all surface detail as it relates to the appearance of the optic nerve. Optic disc drusen that form as a result of an anomalous disc, you're not going to see that obscuration of surface detail. And then finally, what about the retinal nerve fiber layer? Well, typically with optic disc drusen, early on, it may be a little bit thick, but over time, and I can guarantee you this, over time, the nerve fiber layer will thin. And along with that, many of these individuals will show visual field defects with some evidence of progression. It's estimated that upwards of 70% of individuals with optic disc drusen will show this progressive thinning of the nerve fiber layer, along with some progression of the visual fields. The good news is that the vast majority of these individuals maintain good central vision, which is good, given that there is no treatment that is uniformly thought to be productive for the management of patients with disc drusen. One exception: these individuals are at slightly higher risk of developing juxtapapillary or peripapillary choroidal neovascularization later in life, or sometimes early in life. So that's one of the reasons why it's important to watch these individuals with regular surveillance to be guarding against the development of juxtapapillary choroidal neovascularization. But More recently, OCT through the optic disc Drusen consortium, we now have these characteristic features of optic disc Drusen that are identifiable on raster scanning of the optic disc. And these findings were reported in the Journal of Neuro-Ophthalmology in 2018 with some recent revisions, but it goes something like this. So as it relates to disc optic OCT characteristics of disc movement, first and foremost, the Drusen must, at least in portion, be located above the lamina cribrosa. There may be some component of the Drusen that is dipping below, but by and large, the majority of the Drusen bodies are going to be situated above the lamina cribrosa. Point number 2, Drusen always have a signal poor core. And I'll show you some examples of these ovoid structures with signal poor cores. And along with that, there is typically a hyperreflective margin, and that hyperreflectivity is most prominent often at the apex of the Drusen. You can appreciate Drusen through OCT, both as isolated individual Drus, or they may merge together to form aggregates of multiple Drusen. There's an interesting finding called hyperreflective horizontal lines that we see within the optic nerve. And it's debatable as to exactly what these represent. It's thought by some that they may be a precursor to the development of optic disc Drusen, or what is perhaps a more popular feeling in that these may simply be artifacts that are induced, OCT artifacts that are induced by the Drusen. Another very common finding that we find among individuals with anomalous optic nerves, and that can be with or without Drusen, is the presence of these peripapillary hyperreflective ovoid mass-like structures, or FOMS. And I showed you an example of some FOMS lesions earlier. I'm going to show you a number more. These are not, I repeat, these are not precursors to Drusen. They are simply bulging axons. And you can see these in a variety of conditions. You can see this with anomalous nerves, plus or minus Drusen. You can see FOMS in the setting of papilledema. You can see FOMS with tilted optic discs. You can see a FOMS with other disease processes that result in optic disc swelling. But the important thing to remember is that these represent nothing more than bulging axons. The cause of these bulging axons are multifactorial. So here's a classic example of someone that presents with an anomalous optic nerve in the presence of buried Drusen. So before we even get to the presence of the Drusen, the first thing that you can see is that there's pretty much absence of the central cup. 2 is there's pretty good color to the optic nerve. There's reasonable pinkness. There's really no significant obscuration to the major retinal blood vessels, either on the surface of the disc or away from the surface of the disc. We see that there is something of an irregular appearance to the optic disc margin with a little bit of a white halo. More on that later. And then finally, in this case, we see these excrescences that are showing up pretty nicely on this fundus photograph that represent these colloid bodies. These are the buried Drusen. And this is the same case now with a raster scan, spectral domain OCT cut taken through the optic nerve. And what you can see are these multiple ovoid lesions within the optic nerve. They have hyporeflective, or as we also like to call them, signal poor cores. There is a hyperreflective surround, notably at the apex of the Drusen. Here you can see one of these FOMS lesions, notably on the nasal side of the optic nerve. Similar findings here on the temporal side. Here we can see these hyperreflective horizontal lines within the substance of the optic nerve. And just for the sake of comparison, I'm circling the retinal blood vessels here. Now, some individuals, it can sometimes be, some individuals will mistake blood vessels for Drusen. You don't want to do that, but you don't have to. Vessels are always very, very superficial within the optic nerve. They do a tremendous job of shadowing everything posteriorly. Drusen shadow a little bit, but not nearly as well as retinal blood vessels. But the other thing that I think is noteworthy is that you can see the drusen showing up with these signal poor cores. Retinal blood vessels do not have the signal poor cores. And in actuality, there are hyperreflective cores to retinal blood vessels. So let's take a look at another case of an anomalous nerve in the setting of along with optic disc drusen. So this is a 33-year-old woman who was set up for the evaluation of presumed optic disc swelling in her left eye. Her visual acuities were 20/20 in the right eye, 20/20 in the left. Neurologic examination is normal, no headaches, no synchronous pulsatile tinnitus. And looking at the OCT, here we see a raster section through the optic nerve, through the very central part of the optic nerve, and once again, a very elevated appearance to the optic nerve, pretty much absence of the central cup, a slightly negative RPE Brooks deflection, which of course is normal. We do not see fluid accumulating within the subretinal space, but what you do see are these rather large internal aggregates, these prelaminar aggregates with hyporeflective centers that are characteristic of this patient's optic disc drusen. And then along with these ovoid structures, you can see that there are these hyperreflective horizontal lines. Here's a 29-year-old woman who was set up for the evaluation of papal edema. Her visual acuities are 20/20 in the right eye, 20/20 in the left. Normal neurologic examination. She does have a history of migraine headaches, but no synchronous pulsatile tinnitus or other findings that would be consistent with idiopathic intracranial hypertension or elevated intracranial pressure. So looking at her clinical photographs, what you can see are anomalous appearing optic nerves in both the right eye as well as the left eye, kind of an irregular appearance to the disc margin, both in the right eye as well as in the left eye. But if we look at the blood vessels, we see there's really no significant obscuration of vascular detail. We see that there are very, very tiny central cups in this case. We also see that there appears to be pretty good color. And then particularly here in the left eye, you can see peeking through here at about the 2:33 o'clock position, an area, a rock candy-like area that probably represents a locus of buried drusen. So looking at both B-scan ultrasonography as well as fundus autofluorescence, well, most of us or many of us were trained to get B scans looking for buried drusen. And here you can see this very demonstrative hyperreflectivity. But I'm going to caution you with that because in order to get that hyperreflectivity, you need to have significant hyalinization or calcification, which is why in younger individuals, younger patients, if the calcification is not there, you may not see this robust hyperreflectivity on B scan. Now, one of the tools that this is something that's very easy to do is the use of fundus autofluorescence. So here we can see the fundus autofluorescence scan of the right eye as well as the left eye. And very nicely, the FAF is not only showing you that there is drusen, but you can actually count these things individually. So fundus autofluorescence, if you have it, use it, particularly when you're looking for buried drusen. But this is an OCT lecture. Here's a B scan taken through the right eye. And what I'm calling your attention to is this ovoid lesion, notably on the nasal side of the optic disc, signal poor core, elevated optic nerve, something of a small cup, but outward deflection of the RPE Brooks complex, no subretinal fluid, and no wrinkling of the interretinal structures, either on the temporal or on the nasal side of the optic nerve. And looking at the fellow eye, here you can once again see this ovoid hyporeflective lesion within the substance of the optic nerve, hyperreflective surround, that's the drusen, elevated nerve, very, very tiny central cup, negative RPE Brooks deflection, and no fluid within the subretinal space. This is a woman who I saw just a couple of weeks ago, 62 years of age, coming in complaining of blurry vision, right eye a little more so than the left eye. Over the past years, she's got a history of dry eye disease for which she's taking artificial tears. Visual acuities are pretty good, 20/25 in the right eye, 20/25 in the left. No significant history of headaches or chronic daily headaches, synchronous pulsatile tinnitus, or other findings that may be consistent with elevated intracranial pressure. And if we look at her optic nerves, these are her raster scans, right eye on the left, left eye on the right. What you can see are elevated optic nerves, pretty much absence of the central cup, negative RPE deflection, both on the right side as well as on the left. And then here you can see these multiple areas of optic disc drusen, both in the right eye as well as in the left optic nerve. And these are her B scans, really lighting up with abundance these hyperreflective lesions of the optic nerves. I want to finish talking about Drusen with this case. And this is a young man who I've had the pleasure of following for about the past 8 years. He's a 7-year-old young man. I first saw him in 2013. He was sent to me for the evaluation of presumed papilledema and idiopathic intracranial hypertension. Visual acuities are 20/20 in the right eye, 20/20 in the left eye. Normal neurologic examination. Occasional headaches, but no findings consistent with chronic daily headaches, nor evidence of synchronous pulsatile tinnitus. Now, looking at his optic nerves back in 2013, you can see that there are very, very tiny cups in the right, tiny central cup in the right eye, tiny central cup in the left eye, kind of an irregular appearance of the disc margin here in the right, here in the left, but no significant obscuration of the vascular detail, both away from the optic nerve as well as on the surface of the optic nerve. And if you look really, really carefully here in the right eye, you can see this area that I'm circling here with my pointer, taking this suspicious area for what may be optic disc drusen. So looking at his B scans, sure enough, there is evidence of hyperreflective material in the right eye, hyperreflective material, maybe not so much in the left eye. Looking at the raster scan, now remember, this was before the results of the optic disc drusen, or the optic disc drusen consortium. But back in 2013, spectral domain OCT through the optic nerve, elevated papilla, really no appreciable central cup, negative or downward deflection of the RPE Brooks complex, but buried within the substance of the optic nerve. Here you can see these multiple ovoid lesions with signal poor cores and slightly hyperreflective surrounds. These are the drusen in the right eye, and similar findings here in the left. And along with that, on the temporal side of the optic nerve, we have this nice representation of a peripapillary hyperreflective ovoid mass-like structure. And again, these are bulging axons, in this case, due to simply a crowded optic nerve. Now, moving forward to 2019, what you can see are fairly similar photographic findings as compared to 2013. But I think that we'd all agree that now these drusen are becoming more manifest, or they're becoming more visible. So you say to yourself, well, does that mean that you got yourself a better camera? Not necessarily. This is typical in the evolution of drusen. And unlike previous thoughts where, well, it's the drusen that are migrating more anteriorly, it's probably not the case. What's probably going on that is exposing these drusen is this progressive thinning of the retinal nerve fiber layer over time. Hyporeflective Fungicidal Fluorescence in 2019, and you can see this beautiful representation, these reflective areas within the substance of the optic nerve, here on the right, here on the left. And looking at the raster scans through the optic nerves, well, Here you can see these ovoid lesions similar to what we saw back in 2013. We see that there are these FOMs on both the temporal and nasal sides of the optic nerve, the downward deflection of the RPE Brooks complex, absence of the central cup, and we can see a few hyperreflective horizontal lines, in this case, the majority being prelaminar or above the lamina cribrosa. Now, for your viewing pleasure, I just happened to see this gentleman yesterday in follow-up. And these are his fundus photographs looking fairly similar to what we saw before. These are his OCTs looking quite similar to what we saw before. Again, here you can see the multiple areas of drusen in both eyes. But this is what's going on with the retinal nerve fiber layer. You can see that over time, there is this progressive thinning of the nerve fiber layer, both in the right eye as well as in the left eye. And this is commonplace. Again, this is probably why drusen become exposed, why they become more visible. It's not necessarily that they're becoming more numerous. It's simply that the overlying nerve fiber layer is thinning itself down and exposing the underlying drusen. So you say to yourself, wow, with this progressive retinal nerve fiber layer thinning, are there visual field defects? And the answer in this case is yes, there are. And they are somewhat progressive. And furthermore, there's really nothing that is supported within the literature as it relates to the treatment of this. I know what some of you are thinking right now is that, well, what about putting these individuals, treating them like glaucoma patients, putting them on pressure lowering agents? There is no definitive data to support that. It may not hurt, but in this case, this kid's intraocular pressure was always in the single digits. So we run the risk of hypotony potentially by putting this individual, this patient on eye drops that ultimately there is no statistical evidence to support the use thereof. Good news is the vast majority of these individuals do retain good central vision. But again, they're young individuals, time will tell. So before I leave this discussion of anomalous nerves, I want to get back to something that I was paying reference to earlier. What in the world is this white ring that we see surrounding these anomalous nerves? Well, intuitively, we talked about these FOMS lesions as being bulging axons that we see in a wide variety of clinical scenarios. Papilledema, anomalous nerves with or without drusen, pretty much anything that can produce a compartment syndrome within the optic nerve. But I think that what we're looking at now as it relates to these whitish rings that may go all around the nerve or partially around the nerve is probably just the appearance of these bulging axons. So this is the clinical finding that is associated with this OCT finding of a FOMS lesion. So polling question number 2, if we want to pull that up, great. So which of the following is not an OCT characteristic of optic disc drusen? A, the presence of a signal poor core. B, the association with hyperreflective horizontal lines. C, the presence of a hyperreflective surround. D, FOMs are precursors to optic disc drusen. Or E, not sure, that's why I'm here.
And it looks like there's nothing in the chat room, Len, so you're doing very well with that. I think we all appreciate the NBEO quality of these polling questions. Part 2.
Joe, I don't think I see I'm afraid of losing my screen. Do you want, if there's a question, do you want to read it to me?
We will, I will.
Okay,
Greg and I watch them, and as we come across things at appropriate times, we will tell you.
Excellent.
Yep, nothing's good. Nothing's been posted there, Len. Everything's good.
Okay, good.
All right, I'm going to end the poll here. I'm going to share the results. And Len, you can see the results there, correct?
Okay, great. Yeah, so we're doing well. The majority of you, or nearly the majority, jumped on the correct answer, which is D. FOMs are precursors to optic disc drusen. No, they are not. FOMs are simply bulging axons. You can see them with drusen, you can see them with anomalous nerves, but we see them with papilledema, we see them with a wide variety of other optic nerve abnormalities. Great.
Len, as we're talking about, a question did come into the chat room. And what causes progressive thinning exposed in the drusen?
Yeah, that's a good question. I think the best way that I can answer it or explain it is we think about what the drusen represent, and they are most likely the byproducts of degenerating axons. So that as the axons degenerate, we get these concretions, and then the overlying retinal nerve fiber layer is essentially going to thin itself down and kind of rest more near the apex of the drusen. So I think that is probably the best explanation to date as to exactly what is going on, is that the drusen are a byproduct of the degenerating axons. And of course, as the axons are degenerating, the nerve fiber layer is going to thin itself and to a certain extent expose the drusen.
And I'm glad, usually one of the questions that come up, Len, is that, what about, alpha-GAN and its neuroprotective properties? You talked about all IOP lowering medications. And, I think I echo out there because I still get referrals in, people coming in, putting patients on alpha-GAN and IOP lowering medications. And I just don't, I agree. I'm not sure how much benefit there is.
Yeah, the evidence just isn't there.
Yeah, I'm glad you brought that up, Greg. I was going to bring it up as well to put this little chestnut to bed, because even if the people out there don't believe in pressure reduction, well, they still think, well, irregardless of pressure reduction, alpha-GAN has got magical properties.
Yeah.
Glenn, do you want to put that little chestnut to rest?
Yeah, and Joe, you're right. Going back to the ischemic optic neuropathy decompression trial and everything that went along with the natural progression of the disease, it was determined back then that unfortunately brimonidine, it was not able to demonstrate a neuroprotective effect, at least in individuals with ischemic optic neuropathy.
Yeah, when I get asked that question, I'm sure you too, and Greg, my response has always been, it hasn't been proven neuroprotective, because if it was, wouldn't everybody be on it?
Yep. Okay, great. I guess we can move on.
We're good.
So before we get into OCT and neurodegenerative disorders, I just want to say a few things about OCT findings as it relates to the chiasmopathies, or mechanical insult, I guess is a better way of stating it, as it relates to the optic chiasm. And first of all, a little bit of the anatomy. We know that the nasal optic nerve fibers decussate within the paracentral region of the optic chiasm. And going back to high school or college physics, if you think about a force being applied to an object, where there are cylinders that are coursing through the object, there's going to be more relative impact that is applied to those fibers, those cylinders that are crossing over one another, as opposed to those that are going straight back. So that really, in a nutshell, is this vulnerability to the nasal fibers, in that they are crossing and are more vulnerable to that compressive force. And it's also important to remember that these fibers subserve the nasal aspect of the ganglion cell complex. So I want to begin with this case of a 40-year-old man who came in with rather vague complaints of loss of his side vision, both in the right eye as well. The left eye had several months duration, 20/20 vision in the right eye, 20/20 vision in the left eye. We do the optometric equivalent of waterboarding, which is to order a visual field. And what you can see is that there is something that is representative of temporal field loss on the left side, something representative of temporal field loss on the right side, but I don't think that this is necessarily something that we would take to the bank. But if you look at the OCT findings, what you can see here is this significant thinning down of the ganglion cell complex, not so much the nerve fiber layer. This is the ganglion cell complex, and we see this binasal thinning of the ganglion cell complex. So this is the retrograde degeneration of these axons as they're coming into the retina and specifically forming these complexes around the macula. Now, there's in here, just to support this, this is the rest of the case. What you can see is on sagittal view, this MRI without enhancement, showing this fairly large tumor that is growing up from the floor of the cella. This is the chiasm, this is the chiasmal bar that is bent over the top of the tumor. Here we can see the same thing on coronal view. Here's the tumor, here's the chiasmal bar. Here's the same cut with gadolinium with rather significant enhancement of the tumor. So what is the significance of binasal ganglion cell or ganglion cell complex thinning in the setting of a chiasmopathy? Well, this was first brought to light several years ago by the Emory group and reported in Pituitary, where they found not only this ganglion cell thinning as being a highly reliable sign of a chiasmopathy, but being more reliable than visual field testing, particularly for individuals with early disease. So yes, it's important that we do visual fields if we suspect an individual of having a chiasmal syndrome, but I throw this in just to illustrate the value of doing an OCT and specifically looking for that binasal thinning. Now, this could occur, this occurs with insult to the chiasm, but it doesn't necessarily have to be a mass effect. Sometimes we see this with trauma. He's a 31-year-old man, history of a motor vehicle accident. When he woke up, he notices that his side vision is blurry in both eyes. His visual acuity is reduced to 20/40 in the right eye and 20/80 in the left eye. Here you can see, looking at the visual field, pretty classic evidence of a bitemporal hemianopia, left field on the left, right field on the right. But looking at his ganglion cell complex, and I think here you can see it best if you look at the overall retinal topography map, is this beautiful representation of this binasal thinning of the ganglion cell complex. So again, very reliable sign of a chiasmopathy. I strongly suggest that you do this if you suspect an individual of having a pituitary adenoma or some other problem, some other pathology that is compressing the chiasm. And indeed, we see similar homonymous thinning of the ganglion cell complex among individuals with retrochiasmal disorders. But in those instances, the visual fields are typically more demonstrative. And quite frankly, that's a subject for further discussion beyond this evening's talk.
So Len, is it almost as important that if we're thinking we have something in the chiasm, we're so used to saying bitemporal hemianopia that we can just almost continue that sentence now and say binasal ganglion cell loss? Is that just bitemporal and binasal in a sense?
Yeah, I think that's a great point, Greg. And the data certainly bears that out, and that it may be a more reliable sign, particularly in early disease, as compared to what we've thought to be the gold standard as a screening tool, which is the visual field. Wow,
that's awesome. Thank you.
So just and again, looking more at this case here, you can see is traumatic encephalomalacia, in this case due to his motor vehicle accident. So polling question number 3, which of the following is an OCT characteristic of chiasmal insult? A, bitemporal ganglion cell thinning, B, binasal ganglion cell thinning, C, homonymous ganglion cell thinning, D, diffuse bilateral ganglion cell thinning, or E, I'm not sure, that's why I'm here.
While we're waiting, a comment case come in from Dr. Joe Shovlin about GCC losses are markedly even with retrograde degeneration from the occipital lobe area, but isn't there significant delay of up to a year from that area, expecting less time just from the distance perspective?
That's a great. First of all, hi Joe. It's great to be with you this evening. But you're absolutely correct with homonymous defects. If they are pre-LGN in their location, they typically come on quickly, meaning within the first couple of months. If they are retrogeniculate lesions involving the geniculocalcarein pathways, typically there's a longer period of time. So yes, more along the lines of 8 months, sometimes up to a year. Yeah, that's a great point.
Okay, I think we've gotten through, and we see that you really impacted learning. Binasal GCC thinning is the most common response.
All right, great. So we jumped on that one. I guess we can move on. So I want to finish up now by talking a little bit about OCT findings in various neurodegenerative illnesses, notably those findings that are associated with multiple sclerosis, those that are associated with Parkinson's disease, Alzheimer's dementia, and then finally some of the recent work that's been done related to traumatic brain injury. So with that, let's begin by talking about OCT as a potential biomarker in the setting of multiple sclerosis. So, what's the value? Why bother doing OCTs for the evaluation of MS patients? Well, to begin with, if we think about the anatomy, using an OCT or looking at the retina, this allows for the visualization of non-myelinated axons in their native form. So you don't have myelin that's getting in the way. You are literally looking at native construction of axons and potentially much, much earlier changes that can be appreciated with standard neuroimaging techniques, notably MRI. The other thing that we need to remember is that this is science that's been evolving over at least the past 15 years, and that there is a wealth of information now. Much of this beginning with Dr. Laura Balser and her colleagues back at the University of Pennsylvania in the early 2000s, and extending with many, many publications now, looking at both nerve fiber layer as well as ganglion cell abnormalities in the setting of multiple sclerosis, and then using these findings as it relates to biomarkers or indicators of disease progression within the visual and ocular domains. So in addition to OCT, using things like low contrast acuity measurements to be part of the armamentarium, part of the workup, or something that's done for individuals with multiple sclerosis on an ongoing basis. So with that, let's talk a little bit about optic neuritis. So with optic neuritis, it's interesting. Early on, what I'm referring to here largely is retrobulbar optic neuritis, or at least what we used to call retrobulbar optic neuritis, is that generally the optic nerve looks pretty normal. If you look at the OCT, there may be a little bit of thickening of the retinal nerve fiber layer, but then pretty quickly, over a period of several months, there is this very significant thinning, both of the ganglion, both of the nerve fiber layer, as well as of the ganglion cell complex. So here's a 45-year-old woman with a recent bout of demyelinating optic neuritis in her left eye. Visual acuities are 20/20 in the right eye, 20/500 in the left. To go along with that, she has an afferent pupillary defect on the left side. She also has pain on eye movement. And when we look at her OCTs, now her normal eye is on the right, the optic neuritis eye is on the left. On the left side, everything looks fairly normal with the slight exception of just very mild inferior nerve fiber layer edema on the left side. But otherwise, the paramacular region looks normal, as does the rest of the optic nerve. Now, at this point, the visual acuity is 20/500. When this patient presents 3 months later, The visual acuity is now improved to 20/20, but what you can see is something of a paradoxical response. As the visual acuity is getting better, you can see that there is this dramatic thinning down of the ganglion cell layer. Normal ganglion cell layer in the right eye, very attenuated global ganglion cell layer in the left, and we can begin to see this early thinning of the nerve fiber layer and to a certain extent the neuroretinal rim. 6 months later, visual acuity is holding steady at 20/20. We see that there is this persistent thinned appearance of the ganglion cell layer on the left side as compared to the right. But now you can see this very significant thinning of the nerve fiber layer and the neuroretinal rim, more so on the temporal versus other aspects of the optic nerve. So in serial, if we look at the nerve fiber layer measurements over time, as I alluded to earlier, there is something of a paradoxical response, where early on when the vision is bad, the OCT or the nerve fiber layer actually looks pretty good. But then over time, as the vision is improving, we see this progressive thinning of the nerve fiber layer, and this usually plateaus or stops at about 6 months. Here's a patient, 31-year-old woman with a 10-year history of relapsing multiple sclerosis. She's undergoing infusion therapy with ocrelizumab. She previously had an episode of vision loss due to optic neuritis in her right eye. Visual acuity is pretty good, 20/20 -1 in the right eye, 20/20 in the left eye. And if we look at her optic nerves, pretty much a normal appearance to the optic nerve in the left eye. And here we can see predictably a little bit of temporal pallor to the optic nerve in the right eye, which is certainly consistent with her prior diagnosis of optic neuritis. If we look at the OCTs at baseline, and I'm going to blow this up, what you can see is that predictably there is this temporal thinning of the retinal nerve fiber layer in the right eye, the eye with the optic neuritis. But if we look at the left eye, what you can see is that there is some early thinning to the temporal papillomacular bundle fibers on the left side. So what's up with that? Well, we now know that thinning of the retinal nerve fiber can occur in the setting of multiple sclerosis, even in the absence of optic neuritis. Now, you typically don't see the magnitude of nerve fiber layer or ganglion cell complex thinning as compared to patients with optic neuritis, but it is quite common to see some evidence of combined nerve fiber layer and ganglion cell thinning among individuals with multiple sclerosis, even in the absence of optic neuritis. Now, a lot of this goes back to early work that was done at the University of Pennsylvania. This is a study that was published in 2006 in Ophthalmology. This is fairly early in the days of using OCT to look at patients with the myelinating disease, multiple sclerosis, optic neuritis, what have you. But one of the significant aspects of this study is that even though the segmentation algorithms weren't great, there was nevertheless this noteworthy finding of thinning of the retinal nerve fiber layer in individuals with multiple sclerosis in the absence of optic neuritis. Not as much thinning as the cohort with optic neuritis, but nerve fiber layer thinning nevertheless. And indeed, we now know that this is a fairly common finding, and specifically when looking at the temporal or inferotemporal quadrants of the retinal nerve fiber layer. And there are a number of studies also equating this thinning and progression of thinning to other biomarkers of disease activity and disease progression. Here's a 30-year-old woman with a 1-year history of relapsing multiple sclerosis. She also is undergoing infusion therapy with ocrelizumab, no prior history of optic neuritis. And indeed, her visual acuities are entirely normal, 20/20 in the right eye and 20/20 in the left eye. And if we look at her brain, we can see that there are multiple foci that are consistent. This is a FLAIR image showing multiple ovoid paraventricular white matter lesions consistent with the myelinating plaques. And then looking at the OCTs, and if I blow this up, what you can see, specifically looking at the retinal nerve fiber layer, is this selective thinning of the temporal nerve fiber layer, both in the right eye as well as in the left eye. Now, I don't know that this is necessary. I will take that away. This is not necessarily diagnostic for multiple sclerosis, but nevertheless, it is a surrogate biomarker of disease activity. And if we look at everything that's been reported over recent years within the literature, not only is there this thinning of the nerve fiber layer, as well as thinning of the ganglion cell complex, but that both of these parameters can be used in conjunction with other indicators of disease pressure, of disease progression, notably a higher burden of disease as evidenced through serial MRIs. So if we're seeing these findings on OCT, both within the ganglion cell complex as well as within the nerve fiber layer among individuals with multiple sclerosis, in the absence of optic neuritis, is there a consequence? Does this affect vision or visual function as we know it? And the answer is yes, it does, but usually not to a dramatic degree. This is a nice paper that was published just a couple of years ago, specifically looking at both ganglion cell thickness as well as nerve fiber layer thickness as related to visual function, and specifically visual function in the context of visual fields, as well as low contrast letter acuity. And what was determined is that while both nerve fiber layer and ganglion cell thinning are both associated with some decrement in visual function, it's really the ganglion cell thinning that may be a more reliable indicator, more linked to visual dysfunction. And I think that that's something that we're seeing with other optic neuropathies. So more on that with future research. So polling question number 4, which segment of the nerve fiber layer is most likely to show thinning in the setting of MS? And your choices are A, nasal, B, temporal, C, superior, D, inferior, E, not sure. That's why I'm here.
No questions in the chat box, Len?
The responses are rolling very quickly. I think this will be one of our shorter polling questions.
Okay, great. We're doing great, team. We're in the home stretch. You know, nearly everybody jumped on the correct answer, that temporal thinning that is commonly found in the setting of multiple sclerosis. Okay. So moving on, we've talked about OCT with MS. What about Parkinson's disease? And frankly, what would be the science of doing OCT with Parkinson's disease? Well, we need to remember that the retina is replete with dopamine receptors. And the dopamine within the retina is released by amacrine cells. It binds to these receptors and essentially is responsible for normal retinal function, physiology, and essentially it's needed for the retina to thrive. Dopamine is also necessary as it relates to light adaptation and a maintenance of a normal circadian rhythm. So it stands to reason that if dopamine levels are reduced, that we should be able to identify this in some way as it relates to retinal or nerve fiber layer thinning. And indeed, that's true. This is a study that was reported in 2014, one of the earlier studies looking at specifically nerve fiber layer thinning in the setting of Parkinson's disease. and specifically a correlation between the degree of nerve fiber layer thinning as well as the visual hallucinations that are commonplace among individuals with Parkinson's disease, as well as the duration of the disease, suggesting the potential role of OCT and serial OCT testing as a surrogate biomarker of disease activity in the setting of Parkinson's disease. And over the years, there have been a number of studies that pretty much play on this common theme of combined thinning of both the nerve fiber layer as well as the ganglion cell complex in the setting of Parkinson's disease. Interestingly enough, particularly as it relates to nerve fiber layer, very, very similar to what we see with multiple sclerosis is perhaps this temporal versus nasal predilection for circumpapillary nerve fiber layer thinning. Moving on, I want to talk a little bit now about Alzheimer's disease. Of course, there's been a lot reported recently with Alzheimer's disease and specifically with pharmacotherapy or potential pharmacotherapy for Alzheimer's disease. This is a disease that, of course, is credited to the German neurologist and neuropathologist Alois Alzheimer, who in the early 1900s reported on a patient that had been on his ward for a number of years, showing progressive decline in cognitive function. And upon her demise, he was able to harvest her brain. And upon inspection, showed rather interesting findings of general loss of cerebral volume, as well as the sketchy deposits of stuff within the brain that subsequently have been identified as a combination of both the beta amyloid plaque, or probably what we now think of as the beta amyloid plaques, as well as the neurofibrillary tau tangles that are the hallmark of Alzheimer's dementia. So by definition, we can think of Alzheimer's disease as a progressive form of dementia with loss of neurons and the presence of two microscopic neuropathologic hallmarks, and they are the accumulation of extracellular amyloid plaques and intracellular neurofibrillary tangles. Now, Alzheimer's and its impact on the eye and the visual system is not necessarily new. Back in the mid-1960s, there was this interesting paper that was reported in the New England Journal of Medicine by Hinton and colleagues, where they looked at autopsied specimens of individuals with Alzheimer's dementia. And they found an overwhelming majority of these individuals to be showing significant findings, microscopic or as well as macroscopic degenerative findings within the optic nerves of individuals with documented Alzheimer's disease. Now, in the mid-1980s, of course, there were no OCT instruments, so this was based purely on postmortem pathologic specimens. Of course, now with OCTs, this calls into question the use of OCT as a potential biomarker of disease activity in the setting of Alzheimer's dementia. And indeed, there are a number of reports showing various patterns of thinning, both of the retinal nerve fiber layer, as well as of the ganglion cell complex in the setting of Alzheimer's dementia. And there's a particularly nice paper in 2017 reported in Alzheimer's and Dementia by DeHaan and colleagues, where they did a meta-analysis of 29 studies at the time, looking at over 1,000 individuals with either Alzheimer's dementia or mild cognitive impairment, and comparing these individuals to otherwise healthy age-matched controls. And what they found essentially was significantly thinner retinal nerve fiber layers, as well as macular thickness. And we now know that macular thickness is an indirect method of looking at the ganglion cell layer or looking at the ganglion cell complex. So to a certain extent, this really makes sense. I mean, if we think about multiple sclerosis, this is a primary disease of the central nervous system that potentially can result in retrograde degeneration of axons into the retina, into the optic nerve, where they can be evaluated through instruments such as the OCT. So true is that with Alzheimer's dementia. And this may be of significance down the line as it relates to, once again, looking at surrogate biomarkers for disease progression, particularly as it relates to to some methods or newer methods of pharmacotherapy. Now, of course, I'm sure that most of you are aware of some of the controversy regarding the recent FDA approval of aducanumab for the treatment of early Alzheimer's dementia, and of course the firestorm that has created with a number of individuals resigning from the FDA panel, citing that the evidence just wasn't there, given the cost of this agent and the number of individuals with Alzheimer's dementia on an annual basis, that there's very little evidence to support the expense to the healthcare system. It's not up to me, certainly, to opine on the value of this or other forms of pharmacotherapy, but I do think that it's interesting that we, as optometrists, that we be aware of these findings within the retina, not only the nerve fiber layer, but the ganglion cell complex as surrogate biomarkers of disease activity with this most common form of dementia within the Western world. So with that, let's go to our last polling question, which is, which of the following statements is true about the retinal nerve fiber layer in the setting of Alzheimer's disease? A, shows progressive thinning over time. B, shows progressive thickening over time. C, there is no relationship between nerve fiber layer thickness and Alzheimer's dementia. Or D, not sure. That's why I'm here.
Still doing well here, Len. There's no questions in the chat box. Reminder, everyone, a while back, I did put the handout into the chat. If you want to download it that way, it will be in the post-event emails along with the 645 email. So looks like we're doing pretty good here. We'll get one or two to roll in, and we'll end it right now. And you should be seeing the results, Len.
Okay, great. So we're jumping all over the correct response: progressive thinning of the retinal nerve fiber layer over time. Very good. Very good. Okay, so we're certainly in the home stretch. The last topic that I want to cover this evening is the value of OCT findings in the setting of traumatic brain injury. So, of course, over the past 10, 15 years, there's been a lot of attention to repetitive head injury, concussions, repetitive concussions. What does this mean in the short term? And potentially, what are the long-term sequelae that go along with being hit in the head time after time after time? Now, before I get into that, I just want to say a few things about what happens in the setting of concussion and this phenomenon that we now refer to as diffuse axonal injury. So you can really think of this as that when you're struck in the head, there is this very rapid stretching of axons. You can think of it as being kind of like a rubber band, that the axon gets stretched very rapidly, and then it comes back to its normal shape. So that if you look at these individuals with standard imaging techniques such as MRI, essentially the brain looks normal. But as we now know, there are significant biochemical changes that are going on within the brain that potentially have long-term sequelae. Initially is this ionic imbalance, where you have potassium that is rapidly rushing out of these cells. You have calcium that is rapidly rushing into the cells that is creating the situation of massive depolarization. And with that, you have this accumulation of glutamate, which is the body's currency for axonal firing, that just stays there. It doesn't get resorbed back into the astrocytes. It just stays there so that the brain is essentially exciting itself over and over and over again. Now, with time, and particularly as it relates to this chronic accumulation of calcium, calcium has rather deleterious effects intracellularly. It begins to destroy neurons from the inside out. It begins to digest this protein substrate called tau that is a binding protein. It's responsible for holding axonal neurofilaments together. So we can think of individual axons as being composed of many, many smaller neurofilaments. And these neurofilaments are constructed of proteins, these spherical proteins called tubulin, that kind of coil around themselves. And these tubulin molecules are held together by this binding protein called tau. So that's what is ultimately released and gets dispersed within cells. And over time, in the setting of repetitive head injury, begins to form itself around blood vessels, typically at the base of cortical sulci. And that is the histopathologic characteristic of chronic traumatic encephalopathy. So why am I talking about this? Well, very simply, if we think about CTE and the potential use of vision or ocular biomarkers, what is the science? Well, first of all, we know that by volume, approximately 50% of the brain or more is devoted to vision and visual motor processing. So it stands to reason that if there's damage to the brain, that there is going to be damage to vision or visual motor processing, and that we may be able to identify some of this as it relates to structure and function based upon standard examination techniques. As I indicated to you before, with multiple sclerosis, with Alzheimer's dementia, with Parkinson's disease, there is, you can have primary axonal degeneration within the brain that can lead to retrograde degeneration into the retina as well as within the optic nerve that puts us in this unique setting of potentially being able to identify structural and functional changes within the eye. And then finally, there is evidence to suggest with CTE that there is a deposition of tau within the retina. I remember being on a conference call a number of years ago with Dr. Ann McKee, who's one of the leaders in the evaluation, the histopathology of CTE as part of the Center for the Study of Traumatic Encephalopathy at Boston University. And she made this comment. She said, initially when we started looking at these athletes that had donated their brains, we first just started looking at the brains, found tau deposition within the brain, and then further went on to look for this within the spinal cord, and we found it within the spinal cord, and more recently started looking at the retina and have now been able to find that find tau deposition within the retina. And could that be of significance? So that got a number of us thinking at the time, well, if this is what is going on at a microscopic level within the retina, then perhaps there are ways of at least indirectly being able to look for potential damage to the retina through some of the imaging techniques that we use, notably optical coherence tomography. So we did a study where we looked at 46 collision sport athletes, the vast majority of these being retired NFL players, as well as boxers, and looking at their OCT findings, as well as low contrast letter acuity function as compared to otherwise healthy age-matched controls. And what we found, rather interestingly, was a statistically significant thinning of both the retinal nerve fiber layer as well as of the ganglion cell complex in the athletes group as compared to the controls. And that furthermore, this tied in pretty nicely with low contrast letter acuity, is that particularly in those eyes where there were these findings, where there was this thinning of the nerve fiber layer as well as the ganglion cell complex, we found similar abnormalities as it related to low contrast letter acuity. So our suspicion at the time was that it may very well be that what we're looking at is retrograde axonal degeneration, that this is disease that's starting in the brain, and now it's moving into the retina and the optic nerve, and this may be responsible for our findings. Now, we published our results in 2018, and shortly thereafter, there was another very interesting study that was published out of UK among Olympic boxers, and this was a longitudinal study where similarly they found thinning of both macular volume as well as retinal nerve fiber layer among the boxing cohort as opposed to otherwise age-matched healthy controls. But I think one of the most compelling studies, and this is data that was presented by Dr. Randy Carden at the annual meeting of the North American Neuro-Ophthalmologic Society in 2019, was a longitudinal study of veterans looking at individuals with a history of traumatic brain injury due to blast injuries versus controls. And I think that this was particularly significant, not just because it was a longitudinal study, but because one of the confounders of our study was, okay, you've got boxers, to a lesser extent, you have NFL players. How do you know that this is retrograde degeneration from the brain coming into the eye as opposed to simply trauma that's being induced by being struck in and around the globe? Well, with blast injuries, these are concussive waves that results in this rapid stretching of axons and the attendant complications that goes along with that. And the interesting finding of this study was this progressive thinning of the retinal nerve fiber layer in the TBI cohort as compared to age-matched controls, where over time we know that there is thinning of the retinal nerve fiber layer at a rate of about 0.1 microns per year. In this study, there was a much more rapid thinning of the retinal nerve fiber layer of 1.25 microns per year. So again, could this be retrograde degeneration of axons from the brain into the eye? Is this is this essentially a surrogate biomarker of central nervous system disease? Well, I think that, it may be too early to tell, but there's certainly more information, and I think there's need for more clinical trials in order to look for this as a sustained finding. But going back to what we now know with MS, what we now know with Parkinson's disease, what we now know with our Alzheimer's dementia, is that there certainly seems to be this potential for retrograde degeneration. It may be that that's what we're looking at in the setting of these individuals with traumatic brain injury. So with that, it's, OCT, it's not just for evaluating individuals with retinal disease. It's not just for evaluating individuals with glaucoma. I hope I've been able to impress upon you the significance of OCT findings in a number of potentially progressive or potentially neurodegenerative disorders. And I think that this is an exciting area. I think that it's certainly a field where optometry and ophthalmology can add a lot to what's currently being reported in neurology, and certainly looking at these findings as potential surrogate biomarkers of disease activity. So with that, that concludes my presentation, and I want to thank you for your attention, and Joe and Greg, I want to thank you for the invitation.
Well, we're very pleased and honored you accepted our invitation and delivered this really high level talk. Your last slide before this, when you're talking about OCT is not just for glaucoma and retina. I don't know if people really appreciate how many neurologists out there are now purchasing OCTs and using them in the practice. It's just that they don't seem to have a good grasp, and this is at least my experience. And Len, share if you know something different. They don't have often a good comfort level in interpreting those things, and that's why I think it's very important for us as optometrists who know the visual system to work with our neurologic brethren and help them out on some of these things.
Yeah, I think you really hit the nail on the head with that one, Joe. And that, I mean, we get I get these questions periodically from neurology. Okay, we're doing these scans, we're doing them on a regular basis. What exactly is it that we're looking at? Now, of course, the instruments, they are evolving with these, shall we say, AI features, and looking at other algorithms to aid in segmentation, as well as looking at change over time. But at the end of the day, I think that is really a precious opportunity for collaboration between the ophthalmic community and the neurology community.
And Len, I will tell you, in the chat room, you're getting your virtual round of applause. Everybody's saying it's a wonderful lecture, a great presentation, very, very informative. There has been some discussion, as now we're coming toward the end of the year, and COPE, may or may not relax their requirements for live education, and may actually perhaps allow webinars to be considered live. The question, has always come to, are people learning in webinars? Now, from our surveys and from what I've heard tonight, I think unquestionably people learn from this presentation. I know I did. I was looking forward to it, and I thought it was really superb. So thank you, Len. Greg, do you want to bring this on home?
Sure. And I'll say thank you. Len, I asked you to do this lecture well over a year ago. I've been, wanting to hear this lecture, and you certainly didn't let me down on this one. So that was wonderful. So thank you. And also, I think that was Steeler quality, right? You see the Steeler logo here in the back, and knowing you're a big Steeler fan out there, I see the smile there. I think it was Steeler quality that you delivered tonight. So good job tonight.
Greg, that is the highest compliment I've ever received. Thank you.
So with that being said, I will conclude the CE. Len, thank you. This was OCT and Neuro Ophthalmic Disorders, Papilledema, Pseudopapilledema, MS, and other neurodegenerative diseases. Len, thank you again for doing this presentation. And we had myself and Joe as moderators, and Vanessa on here as our COPE administrator. So thank you, Vanessa.